Manjula, just start the live streaming and let us know.
We are live now, doctor.
Okay.
Yeah.
Dr.
Good
Rumas?
afternoon. Yeah. Good afternoon, everyone. Warm welcome to the prelim third session of YOSI iROCK, which is a resident ophthalmic combat of knowledge. The topic for discussion today is cataract, and we are honored to have our judges today with us, Dr. Jeevan Singh Tityal sir, Dr. Parikshit Gupte sir, Dr. Arulmoli Verman sir, and Dr. Sudipta Mitra ma'am. Welcome you all, and thanks for being here with us. We have 5 participating team of postgraduate from different part of country. Our teams are dreaded drucinoids, SNMCI star, oculus curatio, luminescence, and gladiators. Welcome all the teams. Our moderators for this session today is me, Dr. Roma Johari, Dr. Sameer Chaudhary, and Dr. Ritu Singh. We are also joined by a lot of audience and mentor of the participating team. Thank you so much for being here with us and spending your precious time and valuable support. Before we move forward, let's have a brief introduction about YOSI iROCK. So without further delay, we'll go on to meet our governing council members, which is led by our president, Dr. Divyakant Mishra sir, who is committed to fostering collaboration, mentorship, and innovation among young ophthalmologists. He is also joined by Dr. Sonal Kalia, who is the immediate past president, Dr. Karan Bhatia, Dr. Nilesh Kumar as secretary, treasurer as Dr. Aditya Sethi, and joint secretary as Dr. Prasanna B. Ramesh. They are also supported by very dynamic and enthusiastic executive members, and they are really working hard in different forums of YOSI activities. Pardon, sir? They are supported by YOSI members, and they are working hard in different forums to take YOSI to greater height. Now, coming to our team of YOSI iROCK, we are very privileged to have our team leader, Dr. Nupur Goyal, whose unwavering dedication, efforts, motivation, and constant support had strengthened the efficiency of the teamwork. This is the beautiful logo of YOSI iROCK designed by Dr. Nilesh. We have already completed successfully 2 prelim sessions of YOSI iROCK, and we are running the third one now. YOSI iROCK is a national level competition to identify and celebrate the best ophthalmology resident team across India. The registrations are open again. This is a golden opportunity and a learning platform for all the PGs to improve their knowledge and showcase their talent. So please actively participate in this. In this, we'll have each team will have 3 members, and only junior residents are allowed to participate. Senior residents can participate in a fellow face-off event. Top 2 teams from each prelim will go to further round, and they will be awarded prizes. We'll take 7 finalist teams, which will be titled as YOSI iROCK Star or YOSI Icon, and will compete physically at our second annual conference to be held in New Delhi on 5th to 7th of September. Top 3 teams in the grand finale of YOSI Icon will be awarded travel grants and will be titled as YOSI iROCK Superstar. We have 4 rounds in this. First one is a seminar presentation, which is iLeague. Second is the Pupils Got Talent, where they'll show creativity in various forms in view of reels, videos, or any art or creativity. Third is Knowledge Nexus quiz. And fourth one is the Wordsmith War, where they have to unscramble the words. There are multiple audience prizes to be won. So audience, please stay active and keep your fingers on the buzzer when we'll have the quiz round. Now I'd like to introduce my judges. for the session. We have the topic today is cataract, which we know is the most common cause of visual impairment and is the most commonly made diagnosis in our OPD, widely done surgery all over worldwide. So we have the star and stalwart in this field to judge our session. Our first judge is Padma Shri awardee Dr. Jeevan Singh Tityal sir, former Chief RP Center and Dean of AIIMS New Delhi. He has more than 400 publications, more than 8,000 citations, 6 books, and more than 60 chapters to his name. He has regularly conducted instruction courses in various conferences like AAO, ASCRS, ESCRS, APAOA, AIOS. He is amongst the top cited researcher in 2021-24 ranking in ophthalmology. And according to Stanford University, his list of 2% most cited scientists in the world. He has 2 patents credited to his name, and he has multiple awards, Distinguished Service Award, Senior Achievement Award, APA-CRS Certified Educator Award. He was the first Indian to perform live surgery at ASCRS. Apart from Padma Shri, he has also won awards like Shiva Reddy International Award, RP Danda Award, and 4 gold medals are credited to his name. He is a Vice President of AIOS, Vice President IRSI, President Indian Society of Cornea and Keratorefractive Surgery, Past President and Secretary DOS, Past President of FOTI. He is one of the pioneers in ophthalmology. We welcome you, sir, and you have always been a source of inspiration, a role model, and a great teacher for many of us. Thanks for being here. Our next judge for today is Our next judge for today is Dr. N.V. Arulmoli Varman, sir. He's a medical director at Uma Eye Clinic, Chennai. He's a phaco-refractive, cornea refractive surgeon, and he also expertise in glaucoma. Sir has won multiple prizes to his name, not only in ophthalmology, but also in general surgery and forensic medicine. He has many papers in TNOA, AIOS, APAO, AAO. He has multiple publications in national and international journals. And he is also being titled as Phaco Dynamite because he is one of the super fast surgeons. Welcome, sir. And sir has always emphasized the secret to mastering phaco-dynamic lies in the knowledge and application of our high school level physics. So welcome here, sir. Thanks for being with us. Next judge for today is Dr. Parikshit Gokte, sir. He has 109 publications, more than 400 national and 112 international presentation. He has also written 15 books chapter, and he has multiple times achieved this Rangachari Award for Best Paper in AIOS. He has taught, demonstrated, and lectured on cataract and strabismus surgery in 33 countries. He has done multiple adult cataract surgeries and thousands of pediatric eye surgeries. He is a member scientific committee AIOS in 2020 to 23, member ARC, secretary ISGEO, section editor Community Ophthalmology and Research IGO, member editorial board of Community Eye Health, member editorial board and general of Clinical Ophthalmology and Research, president Maharashtra Ophthalmology Society, chairperson scientific committee and treasurer. He was a secretary at International Society of Manual Small Incision Cataract Surgery, vice chairman, member of ethic committee and AIOS. He has also done PhD and master's guide in 3 universities. He is also an ex-IPS officer. We welcome you, sir. And you are a good teacher, wonderful surgeon, and always supportive to the young ophthalmologists, not only in their academic learning, research, as well as refining their surgical skill. We hope to learn some pearls of ophthalmology from you in this session today. Next, we have is very dynamic Dr. Sudipta Mitra ma'am. She has done her fellowship from Shankar Netralaya. She is LASIK trained and flex certified. She is the founder director of RMI Foundation, Hubli, and she's the senior consultant at Silver Line Eye Hospital, Manipal Hospital, AM Medical Center, Kolkata. She has more than 2 decades of practice, and she's a prolific phaco surgeon, expert in handling complicated and challenging cases. She is expertise in glaucoma, medical retina, oculoplasty. Basically, she's a pan-ophthalmologist with a special interest in refractive surgery, LASIK and phakic IOL. Many awards and publications are credited to her name, and few of them are Best Video Award in FIFA in refractive surgery in AIOC, Best Video Award in IRSI Winter Conference, Best Paper Award EIZOC Annual Congress, and she's also the winner of IPCL Gold Medal in Users Meet Bangalore. She has multiple publication and she's an international faculty and speaker to Bangladesh, Iraq, Russia, Uganda, Singapore, Nepal. She's presently as a chairman of Scientific Committee of Ophthalmic Society of West Bengal. Welcome, ma'am. And for her, the complicated cataract are just like bread and butter. So we'll definitely learn better tips to handle cataract from her. Thanks for being here with us. And now I'll invite Dr. Sameer to introduce our moderators.
A very good afternoon to one and all. So I'll be introducing the moderators for this session. Next. Can you go to the next slide, ma'am?
Yeah.
So this is me. I am Dr. Sameer Chaudhary. I completed my MS Ophthalmology from Arvind Eye Hospital, Madurai, currently working as a consultant. I am also an executive member of YOSI, and I have over 25 publications, one book chapter, and I'm a reviewer for multiple international journals. I have completed more than 3,000 cataract surgeries, and I've also served as a formal SICS trainer. Next. Dr. Roma Jorish, who is presently working as a glaucoma consultant at Shri Shankara Netralaya, Hyderabad. She completed her MBBS from KMC Mangalore and did her DO from Bangalore Medical College, followed by her MS from CMC Vellore. She completed her glaucoma fellowship from HV Desai, Pune, and worked as a senior associate in PD Hinduja Hospital, Mumbai. She also received a gold medal during her MS and was awarded as a resource teacher in AIOS PG refresher course. She is also the editor of journal Current Medical Issue. Next. So Dr. Ritu Singh, who is currently working as an assistant professor at the CAPFIMS campus of AIMS. She pursued her MS ophthalmology from King George KGMC Lucknow. She has more than 25 presentations at national and international forums and 6 index publications. She is also the recipient of the AIOS IGO Silver Award in 2022. So next, I would like to invite Dr. Ritu to introduce our participants for the current session.
A very good afternoon to everyone. I'm here to present the participants who are the actual backbone of this YOSI iROCK. Next slide, please. Yeah, the first team here is Team Luminescence, and we have 3 participants, Dr. Rajendra Prasad, Dr. Ridhima, and Dr. Ria. We also have their mentor, Dr. Aparna, with us. Next slide, please. Interesting name, Gladiators. The second team, we have Dr. P. Monica, Dr. Shreya Jain, and Dr. Chirag Kalra from the Arvind Eye Hospital and PGIO. Dr. Chirag is from DDU Hospital. We have their Dr. Shashikant Shetty sir is their mentor. We have him here with us. Next slide, please. The third team is Dreaded Rusinoids. Dr. Shireen Gupta, Dr. Mehak Gupta, and Dr. Ayush Arya from GNEC are here with us. And we have the mentor, Dr. Kirti Singh ma'am, here with us. Oculus Curatio, we have Dr. Abhinav Joshi, Dr. Saurabh Nivdekar, and Dr. Uttar Bhatt with us. And I guess we are expecting their mentor soon. Next, please. The last team of today is SNMC iStars. We have Dr. Siddhi Mathur, Dr. Akshika Dhamija, and Dr. Vinesh Sharma with us. And their mentor, Dr. Arvind sir, is here with us. Dr. Sameer. Yes, all right. We also have our dynamic secretary, Dr. Nilesh sir. As we say, Chhatra Chhaya ke bina koi kaam nahi hota hai. That is how he is for us. Would you like to give any comments, sir, here?
Thank you so much, Dr. Ritu, for those kind words, but I don't think I deserve that. It's not Chhatar Chhaya, it's all the teamwork that has taken this forward. I think when we started with this current team, there was a vague idea that we wanted to do something because it was so humongous. We didn't have any database of how many residents are there, how many colleges are actually offering post graduation. But kudos to Nupur ma'am and her unending zeal that she formed a team. Actually, the iROCK team that we see today is handpicked by her, and she got on the task, collected all the data, and now we have around 50 teams right now, and we are opening up submissions to more. So we will have a grand tournament throughout the year, culminating at YOSICon, which will be our event. I am extremely grateful to the judges who are present here. I think Tityal sir, Parikshit sir, Arun Moli sir, and Sudipta ma'am. Everybody is stalwart in their field, in the respective field and the respective institute, and all over India. So we are going to learn a lot from them. And I would like to extend a heartfelt welcome to all of you to please be a part of YOSICon at Finale and bless us physically over there so that you can see the year-long effect, how whatever they have done throughout the year, how it culminates. Thank you so much for having me also, and looking forward to this episode.
Thank you so much, Dr. Nilesh sir. I'll also welcome Dr. Roma to get back to the general instructions now.
So we have 4 rounds in this. Round 1 is the iLeague, which is a seminar presentation. Round 2 is creativity round, where they have to show videos, reels, and art and craft work. Round 3 is knowledge nexus, and round 4 is Birdsmith war. Now I'll request Dr. Sameer to take over the round 1.
So we'll be starting with our first round, which is the iLeague seminar presentations. Ma'am, next slide. So the rules for the first round are one member from each team will present on the following pre-decided topic. The presentation time will be 5 minutes, and any negative, there will be negative marks for exceeding the limit. So after each presentation, after each round, the team, we request the judges to have a Q&A round. They'll be asking questions to each team, and the time allotted for that is 2 minutes. So the total marks for each presentation will be 20, and the theme for the presentation is cataract. So now I would request our first team, Luminescence, to present on traumatic cataract. So I would request Dr. Roma ma'am to stop sharing her presentation.
A disclaimer here that if you exceed the time, you'll have a negative mark in teams.
And I would also request all the judges to mark them. We have shared the Excel sheet with all of you. So please mark them in the Excel sheet. Towards the end of the 2 rounds, you can share a screenshot with me or any of the moderators.
Dr. Ridhima, can you put it on full screen mode, please?
Your time starts now.
Dr. Edema?
Ma'am, I was mute. Can I start now?
Yeah.
Please do.
Reset the timer, yeah, please. Just give me a second. Yeah, go ahead.
Please go.
Good afternoon, everyone. I'm Dr. Ridhima from Team Luminescence. I'll be presenting on the topic traumatic cataract. I would like to thank Dr. Aparna Singhal ma'am for moderating us. Incidence of ophthalmic trauma worldwide is 55 million, with prevalence of blindness being 1.6 million. It is more common in children and young adults. Pathogenesis includes, it can be due to blunt or penetrating trauma. Blunt trauma is due to coup and counter-coup injury leading to rosette cataract, while in penetrating trauma, there is a capsular breach leading to cataract development within hours. Examination, we have to check for visual acuity with Snellen's, pupil reaction, and look for RAPD. IOP assessment is must, and slit lamp examination, look for signs of trauma like sphincter tear, iridodialysis, hyphema, subluxation, osseous ring. Different morphologies of traumatic cataract are rosette cataract, membranous. They can be white soft cataract when there is breach in capsule, or total cataract. Fundus has to be checked with indirect ophthalmoscope as well as 90D. It is not always possible due to media not being clear. Then rule out open globe injury first, and then go for B-scan and UBM to check for posterior capsule status and dislocation of lens. ASOCT has advantage of being non-contact, but it needs optical clarity. X-ray and CT orbit done to rule out foreign body. When should we intervene? Whenever there is functional decrease in the visual acuity, there is inflammation due to lens matter, capsule rupture, and when we cannot assess the posterior segment. Timing of intervention can be primary cataract extraction with primary wound repair, which has advantages of better control of inflammation. Posterior segment evaluation is possible. It prevents amblyopia, and it is more convenient and cost effective for the patient. But it can lead to refractive surprises, and thorough assessment of injury is not always possible preoperatively, and surgery can be difficult in case of media opacity. Second setting cataract surgery has advantages like eye is quieter, better IOL calculation is possible, and diagnosis is more certain. But adhesions can lead to difficulty to put IOL. Second setting cataract surgery is the preferred choice because this study has shown that delaying cataract surgery for 2 months after initial repair doesn't change the visual outcome or any complications significantly. But primary cataract removal is preferred in case of extensive capsular rupture. There are certain challenges in open globe injury, like biometry is not always possible. Therefore, take contralateral eye biometry or an average K value of 44. Surgical approaches can be anterior or posterior. Anterior limbal approach is done in case of non-dislocated cataracts or anterior lens dislocation, while posterior approach is via pars plana, which is done in case of PCR or posterior lens dislocation. If there is vitreous in AC, do add limited anterior vitrectomy with cataract extraction. In case of posterior segment injury, go for early pars plana with lensectomy and vitrectomy. In children, there are a lot of challenges because trauma assessment itself is difficult. There is high inflammation and vitreous traction. Rate of PCO formation is also high in children, and anesthesia risk is also high. In children, primary cataract removal with or without IOL with primary posterior capsulectomy and vitrectomy is done. Cataract surgery should be done within 1 year of trauma to prevent amblyopia. Now, when should we put IOL? Visual improvement doesn't differ between primary or secondary IOL implantation. In children, IOL should be implanted early to achieve good visual outcome. Management of subluxated or dislocated lens depends upon the amount of subluxation, where we have to look whether we can save the bag or not. In less than 4 clock hours of subluxation, we have to use capsular tension ring or segment. 4 to 9 clock hours, use Sionis ring. Beyond 9 clock hours, do lensectomy with vitrectomy with AC IOL or SF IOL. In post of retinal periphery examination has to be done. We have to counsel patient regarding the social rehabilitation. Protect other eye is very important, and explain the signs and symptoms of sympathetic ophthalmitis. In children, astigmatism and near correction has to be given. Monoocular aphakia is taken care by aphakic glasses, and amblyopia should be treated very promptly by occlusion therapy and squint surgery if needed. And prevention is always better than cure. Go for protective eye gears to prevent occupational trauma. Thank you.
Great presentation. Finished well within time. Now, I would like to invite our judges to throw upon some questions and start this Viva. Dr. Tityal, sir.
I think good presentation, Dr. Ridhima. Few things which I wanted to add on to your presentation, which will make things more complete. One, important examination which you have missed is a gonioscopy. Because injury, which may be a blunt, you have totally missed out the gonioscopy part, angle recession part, that you missed out. And second was, always these patients are young and the surgery has to be done under general anesthesia. Sometimes the findings are, not visible in a routine examination. You tend to get new findings on the table when the child is under anesthesia. Your consent part you are missing totally. In trauma, consent is one of the most important part. So consent should have been taken very appropriately with the parents or relatives. Sometimes, we may have to invite them inside the OR to show these are the findings, and we have to do a different type of surgery or modify your surgical approach also. The third important part, which is important, is the documentation. So you had, OCT, UBM, you talked about that, but The diagrammatic representation of a picture of a case should be there, or a photograph should be there, which is a very important aspect for a medical legal thing, because all trauma cases are medical legal. And we have to give a potential visual acuity for these patients, what is going to happen before you take the patient for surgery and after the surgery also. And that has to be documented very effectively. And surgery is okay. You talked about, first stage, second stage, or a primary surgery, repair, all those things. But important thing in a trauma, which may be sometimes open globe injuries, is the prevention of infection. The prophylaxis has to be there, which may be, intravitreal, intracameral, other things. You never talked about those things, which was totally missing in your presentation. And other thing is, you talked about in one slide, talked about one study. As a young student, this is not a good way to presentation. You should say, like Titial et al. Had, in 1928 or 1958, from this institute reported this. So that has the value. So you make a, impact from now onwards. Talk about that, because that's a very important, you can say, thing on a slide which makes authenticity. So if you have put 2, 3 references, those has to be mentioned in your presentation. The important thing. Like suppose you say this study from NN, a study from AIMS, that makes a huge difference in your presentation. So I think clarity was there, but you had to make more appropriate points in that. Otherwise, the presentation covered most of the things. Thank you, Ridhima.
Thank you so much, sir.
Thank you, sir.
Now I would like to invite Dr. Arul Moli, sir, for his questions or his comments.
Yeah, Professor Titial covered everything very well. What I would like to mention again, like Dr. Titial said, in these cases, when you look at blunt trauma, we should examine the patient lying down. We would do that anyhow when we do an indirect, whenever you do it, but you'll find a lot of findings, the way that the lens sits, the movement of the lens, subluxation, so many other things you would find out is exaggerated in the posture that you're going to operate upon the patient. That is one. And of course, all of these patients, the most important, you mentioned it in the beginning, please record vision first. Often patients have a trauma in one eye, it's a child, and the child doesn't say that there's no poor vision in that eye, is doing well because vision in the other eye is good, and the parents don't accept and something goes wrong later. So in front of the parents, the vision should be recorded and documented very accurately, and that's extremely important. And of course, cleaning the wound, doing prophylactic antibiotic rinsing or prophylactic antibiotic intracamerally or intravitreally is probably the first step in an infection which is with open globe injury, if you suspect anything like that or a penetrating injury. Other than that, this is a good presentation.
Just one question. Sorry, I didn't ask the question to you, Dr. Ridhima. In open globe injuries in children, which type of endophthalmitis is more common? Which organism? Most common?
So Titial,
you have to put as sutures. You have an open globe injury, and it is a corneal scleral injury along with the lens rupture. So, what would be your norms for repairing this corneal skull suture? How would you proceed?
Sir, answer to the first question is streptococcus. Sir, pardon for the second question. There was a voice break.
No, we have injury which is involving cornea and sclera both, and you have a ruptured lens also. So how do you proceed this case?
Sir, we have to maintain globe integrity, so corneoscleral suturing has to be done, and lensectomy we will do.
No, how you have to do? How would you proceed for suturing this?
Okay. So first we will do exploration and find extent of injury. Then we'll start from the limbus and as a landmark and suture the sclera first and.
Okay. ठीक है. Dr. Parikshit.
Thank you, sir. You've covered most of the things. Dr. Ridhima had a very lucid presentation. A few things I could said is, one is you also tell us about the importance of B-scan, because We want to know how good or bad the posterior segment is. And even if we can do a good indirect ophthalmoscopy, a B scan is something that is documented. As Dr. Arun Mosi said, we have to think of the person's vision. So similarly, a B scan documentation is important. And also how the injury was caused, because was it accidental? Was it on purpose? Was it an assault? Because as far as we doctors are concerned, we are just concerned about suturing the eye, treating the eye, and restoring the vision. But a lot of patients' complaints and patients' reaction may be depending upon how the injury had occurred and in case there are any medical legal implications into it. So that also I think we should look into.
Thank you, sir. So Sudipta ma'am, Dr. Sudipta ma'am, any questions from your side?
Yeah, not in particular, because most of the points have been very well covered, and presentation was pretty good, I would say. Yes, of course, you need to look into the infection part very importantly to see that, because most of these cases are having multiple injuries. So you have to have certain things in your armamentarium. Be ready for surprises when you're treating these patients. And I think if these points can be incorporated in the presentation, it would take a better take, I think, teaching part. That's all. Thank you.
Thank you, ma'am. Now I would like to invite the mentor of Team Luminescence, Dr. Aparna Singhal, ma'am, to give her comments, encouraging comments for her team. Ma'am.
Yeah, thank you for having me on this platform. I'm really honored and humbled by sharing the platform with such great personalities. And I'm really happy to have mentored Team Luminous for today's presentation. I'm really happy that Dr. Ridhima could put it forward so nicely, and the nice comments and the questions. Thank you so much.
Thank you so much, ma'am, for joining us. Thank you, ma'am. With this, we'll move on to our next presentation. So now I would like to invite Team Gladiators to present on posterior polar cataract.
Shall I start, ma'am? Start. Ma'am, can you just reset? You lost your 2 seconds. Start. Good afternoon, all. I am Monica from Team Gladiators. Posterior polar cataract. It is a multiple concentric rings of gray-white opacity present at the posterior pole of the lens, typically in the center. Usually it is congenital, can also develop later in the life. 65 to 80% of bilateral involvement has been seen, and it also has an autosomal dominant inheritance. It is associated with persistent hyaloid artery remnants, posterior lenticonus, lentiglobus, and persistent hyperplastic primary vitreous. According to Duke Elder's classification, it is a stationary type and a progressive type, which has an onion oval appearance. In Dalijit Singh classification, we have a type 1 where there is a posterior polar cataract with PSCC, and type 2 where there is discoid opacity with onion ring appearance, and type 3 you have a dense white spots at the edge associated with PC thinning, and type 4 there is a combination of above 3 types along with nuclear sclerosis. On ASOCT classification, it is described based on the amount of the clearance between the posterior polar cataract and the capsule. In type 1, there is an intact PC along with clearance present between the opacity and the capsule. In type 2, you have an intact PC with a clearance in the periphery, but in the center, PC is not seen. And in type 3, there is an absence of intact PC. Patient presents to us with a glare, difficulty in reading fine prints and photophobia, reduced contrast sensitivity. On slit lamp examination, we see a bullseye appearance, and if there is anterior vitreous, it represents there is a defect in the posterior capsule. The patient should be done a thorough preoperative counseling on the possibility of nuclear drop intraoperatively and long operating times and delayed visual recovery. If there is a residual plaque, there will be a need for NDR capsulotomy and the possibility of pre-existing amblyopia. During the phacoemulsification, the parameters should be lowered.
with a power of 30 to 60%, bottle height of 55 to 70 centimeters, and aspiration rate of 15 to 25 ml per minute, and vacuum 30 to 60 mm of mercury. The surgical techniques to be considered in PPC cases are avoiding rapid building up of hydraulic pressure within the capsular bag and creating a mechanical cushion above the weak capsule with maintaining a closed chamber techniques. Ideally, a temporal 2.2 mm incision is preferred and a short scleral tunnel incision is preferred over a clear corneal incision. Haripriya et al. Have described a separate infusion and aspiration instruments placed through watertight incisions of 1.4 mm so that AC is maintained with the infusion from separate irrigating chopper. Capsular excess ideally should be of 5 mm, not too large and not too short, and inject a cohesive material to maintain the chamber. Hydrodelineation is done to create a mechanical cushion of the epinucleus and avoid hydrodissection and nuclear rotation. There is a technique called inside-out delineation where a trench is made at right angle and the hydrocannula is directed towards the lens fibers and you can see the golden ring appearance. Nucleotomy, we follow a reverse bloom technique where we remove the removal of nuclear material is done first, followed by peeling of cortical matter from outside to inside, which is like a reverse blooming flower, and followed by removal of the posterior polar cataract finally. The two complications encountered during the surgery are posterior capsular rupture and a nucleus drop. According to few surgeons, femtosecond laser is preferred over phacoemulsification and then a small incision cataract surgery. So coming to the incidence of posterior capsular rent, it varies considerably and the incidence of PCO in routine cataract surgery is less than 1%. If it is with the posterior polar cataract, it can be around 4% to 36% and femtosecond laser 4%. Actually, PCO can happen at any step, even while forming the AC or during the visco wash. As you can appreciate in this video, it has occurred during the visco wash. Conclusion, complication can occur at any stage. Surgeons should take all precautions to minimize the risk. With appropriate management, good results can be achieved. These are my references and thank you. I would like to thank Dr. Shashikant Shetty sir for being with us today on this presentation. Thank you.
Thank you. Thank you, Team Gladiators. That was a great presentation, finished within time. Now I would like to invite Dr. Sudeepta ma'am for her questions and comments.
Yes, thank you. Of course, it's a very nice presentation. Congratulations. But I would still like to add some points. And the most important part of it is when you when you get a posterior polar cataract, you can ask the history in the other eye if the patient has been operated in the other eye. So that helps you recognize if the other eye, the PC had opened up, what complications had happened, so you can get ready. Secondly, whenever you are attempting a posterior polar cataract, you need to mention that you should have certain other things in your armamentarium in the OT because you have to be ready for vitrectomy. As you said very correctly, it opens up at any moment. So you have to be ready with your vitrectomy cutter. You have to be ready with your multi-piece IOL to manage it. Third point is, whenever you are doing these type of cataracts, you cannot leave the anterior chamber shallow at any point. Because whenever you leave it shallow at any point, if there is a rupture already there, it will open up very soon. So these are the most important points of posterior polar cataracts, which you need to see and learn. Otherwise, the presentation is very nice. I congratulate you on that. Thank you.
Thank you. Thank you, ma'am. Dr. Parikshit, sir, any comments and questions?
No, I think she's put it very well. And I think there could have been something more on literature and on comparison, but still the jury is still out as to which is the better technique for a posterior polar cataract, whether it is femto or SICS or phaco. And proponents of each one of them will say like their technique is the best. So it's finally what is left with the surgeon and for the surgeon to decide. But another thing which I think they should have also mentioned is whenever we operate a posterior polar cataract, chances of something going wrong are definitely more than any other routine cataract surgery, which is said at the beginning of the presentation, but that is something that has also to be told to the patient. So the patient also knows that perhaps the outcome may be guarded and there is something different or difficult that the ophthalmologist is going to do.
Thank you, sir. Dr. Titayal, sir.
Okay. I think nobody asking question. Let me ask question to Dr. Monica. What do you understand by fish-tail sign?
Sir, it is seen in association with lenticonus, and whenever there is PC dehiscence, the vitreous attachment also gives the appearance of fish tail.
You talked about, inside-out delineation in one of your slides. Who reported this?
So Vasavada et al.
There are so many Vasavadas, no? Doesn't matter. Some people talk about, doing a proper anterior, capsular rhexis is a very important aspect. And there's a concept of doing an oval capsular rhexis. You have any idea on that? No? Okay, you nicely talked about anti-segment OCT as an important tool in difficult cases, and it's true for our posterior polar cataracts also. But there are features which are we call high-risk features. So which are those morphology which has a very high incidence of posterior capsular dehiscence happening during the surgery? Can you name those three morphologies based on an anti-segment OCT?
So when there is no clearance between the opacity and the posterior capsule, and also when there is absence of intact PC. Like
any other description? People have given a name for that, So that is basically, three shapes are very, very high risk for a capsule giving way during surgery, almost 90 to 100% cases. And these are conical shape, moth-eaten appearance, or eclectic appearance. If you have these three appearances in a OCT, they have a very high incidence of rupture. Rest 90% cases are, are a conventional posterior polar cataracts seen as senile cataracts. We always talk about not to do a hydrodissection in these cases, do only delineation. Is it true?
So type 1, we can go for a hydrodissection.
Okay. Not all cases, if you can delineate the posterior capsule from the posterior, the polar disc, maybe yes, you can do a dissection also. Okay. Thank you, Monica.
Thank you, sir.
Great question, sir. A lot of learning points for me as well. And well answered, Dr. Monica. Dr. Arul Moli, sir.
Yeah, there's only one point to make. You should have mentioned that every time you come out, the infusion, do not let the chamber collapse. You have to fill in viscoelastic from the side port. It's extremely important because that alone can completely break up the capsule. One question to you, you finished your surgery very well, everything is good. You see the posterior plaque that is stuck on the capsule at this point of time. Would you attempt to remove it? Will you not, and why?
So we can plan a NDR capsulotomy at a later date.
That's fine. So you will not remove it on the table?
Because it might cause any weakness.
Yeah, perfectly right. No, it will not cause weakness. What appears to be a small layer of breadcrumbs there, you touch it and it'll split apart.
Yes.
So if it doesn't come off on its own, better not to go dig around there when you know it's a posterior polar. If it is a PPC with a plaque, that's the difference. If clinically you're sure it's a PSC, I'm sorry, it's a PSC cataract, posterior subcapsular cataract, not a PPC, and they see a plaque there, you can go and pull it out, even use a capsular rhexis forceps and peel it off. When you're sure it is a PPC, do not touch the posterior capsule.
Yes.
Thank you.
Thank you, sir.
Thank you so much, sir. Now I would like to invite the mentor of Team Gladiators, Dr. Shashikant Sethi, sir, to give his comments.
Good afternoon, everyone at the outside. It is very nice to sit with these great luminaries, mentoring the students. And Dr. Monica had a very excellent presentation. The person who invented that oval rhexis, I think, is Dr. Kirandeep Singh, who was talking about the oval rhexis.
Yeah, correct. Absolutely correct.
Yes. Thank you, sir. Thank you very much for your very good comments, nice comments. Thank you, sir.
Thank you so much, sir. Thank you for taking out time and joining us and encouraging your team. Now I would like to invite the next team, the dreaded drusenoid, to present on pupil expanding devices.
Start, please.
We cannot hear you due to noise. Good afternoon, everyone. I'm going to present on pupil expansion devices. So there are 4 ways of navigating through a small pupil: pupillary stretching, operative maneuvers, iris hook or retractors, pupil expansion devices. Pupil stretching can be done by using 2 instruments, by manually stretching the pupil 180 degrees. Various instruments can be used. Also, we can use brown pupil dilator, which consists of two hooks 180 degrees apart, or cube pupil dilator. We can also use Beeler pupil dilator, in which there are 4 micro hooks, out of which 1 micro hook is towards the subincisional port and other 3 are 180 degrees apart. Operative maneuvers are also there, like using phaco sleeve and using lens capsule by lens nucleus by flip and chop technique. Other methods are iris hooks on retractors. First one is the macule self-retaining titanium mechanical hook. Also, which is more commonly used, is a nylon iris hook with silicone sleeve. We generally use 4 to 5 iris hooks. Now, we have various expansion devices. First is the Malugin ring. It is a square-shaped device which is a 4-0 polypropylene made. It has 8 points of fixation. There is also modification of Malugin ring, which is Malugin 2.0, which can be inserted via a small incision. This is a video depicting how to insert a Malugin ring and how to remove it. Now, there are various modifications of Malugin ring, like femtosecond laser-assisted cataract surgery. There is Agarwal's modification, in which we can tie a thread through the Malugin ring and can be removed if there is PCR. For ectopic pupil and ectopia lenses, Malugin ring can be used and can be displaced towards the lens. Zonular instability and small pupil, in which a capsulorhexis can be inserted into the ring. Also, it can be used in a triple procedure with positive vitreous pressure. Gupta ring is an Indian alternative of Malugin ring, which is cheap and more commonly used. BHEX pupil expander devices. It is made of polyamide and give a pupil dilatation of 5.5 mm. It can be used in a shallow anterior chamber and in combined phaco and vitrectomy surgeries. Others are Martian pupil dilator, which gives a dilatation of 5 to 6 mm and gives an even tension around at 300 degrees. It caused less iris trauma. Milvella perfect devices. It is made up of polyurethane. The portion of a ring produced outside the phaco, so it becomes easier to remove this ring. iRing pupil expander. It is made of polyurethane. Pupillary dilatation is 6.3 mm and there are 4 outwards projecting triangular portion with holes. It helps in positioning the device properly. Asia pupil expander is also used commonly. Here, 2 devices are inserted at 180 degrees, 90 degrees from the main port. If we insert at 180 degrees, there is a quadrangular opening. If it is less than 180 degrees, then a trapezoidal opening is made. Grether 2000 pupil expander devices. It is a clear soft silicone
ring, it is available as a preloaded sterile device. It causes a pupillary dilatation of 6.3 mm, and there is an incomplete ring and a strap which connects the end of the rings. Then expand anti-iris speculum. It is thin nitinol wire made device which has an octagonal pupillary opening. YOSI's iris expander. It has 4 pockets at the corners to lodge the iris margin, and it decreases the trauma to the pupillary margin. Then Canabrava ring is used in case of iris defect and coloboma. We can clearly see the difference in using Canabrava ring and Malugin ring. It has a 300 degrees of the circle. Hydrogel dilators are also available like Hydroview and Sipser Ideal Iris ring. Now, various complications are also there like iris sphincter tears, hyphema, iododialysis, increased surgical time, endothelial touch and damage, etc. Thank you.
Thank you. Thank you for your presentation. Now I would like to invite Dr. Parikshit sir to throw his questions and comments.
My God, I didn't know there were so many different kinds of pupil expanders and dilating devices. So thank you. That's something new you've taught us. But what are the simple things that we can do so that we don't need to use these dilating devices preoperatively?
So there are various ways in which we can prevent using these devices. Like preoperatively, we can use NSAIDs like like FLUR, and also intraoperatively, we can use adrenaline inside the eye so that there is dilatation. Also in the fluid, we can inject the mydriatic agents in the irrigating fluid only so that it can keep the eye dilated all the time. Also, by viscoelastic also, we can dilate the pupil. Then we can also inject the bolus intracameral mydriatics and local anesthetics inside the eye. And then cotton plates are also inserted in the inferior fornix to keep the eye dilated with the mydriatic. Then, so these are the ways. Also, sphincterotomies can also be done to prevent pupil expanded device.
Or we can do something like a small keyhole and then suture the iris back. Excellent.
Okay, sir.
Thank you.
Thank you. Thank you, sir. Dr. Titial, sir.
Yeah, good presentation. I don't know your name. You are Mahak.
Yes, sir.
Good presentation. Mahak, pupil expander devices, you named so many of them. But the first important thing is why they are needed. So your presentation should start with what are the various indications for using these devices and which are those conditions where these devices can be opted out. Like not every case you'll go for a intracameral expanders because there are situations where you can't use them. You have to use the hooks there in those cases. So if you have divided this presentation, okay, these are various types of expanders and hooks, and where are they going to be used, when they are supposed to be used, what are the advantages of each devices and what are the disadvantages of each devices. That would have made this presentation fantastic. One question for you. Why does pupil, constrict when you manipulate the pupil?
Sir, when we manipulate the pupil
Surgically, when you are manipulating, sometimes pupil constricts.
Yes,
Why?
sir, because of the release of prostaglandins. So that causes meiosis of the pupil.
So in those cases where you have to use these expanded devices or hooks, would you have more inflammation in a post-op period?
Yes, sir. It will
If
cause
yes,
more.
then what should be the management for these cases?
Sir, we should use more frequency of the steroids, topical steroids.
So my idea to ask this question was, you have to say these are indications, these are devices, these are situations, and this can happen, and this has to be a treatment for them. Okay. Understood?
Yes, sir. Thank you, sir.
Thank you, sir. Dr. Arul Moli, sir.
One of the most important points that's been missed out is to mention about floppy iris. Most of these non-dilating and rigid pupils also turn out to be floppy. And one other point you'll have to mention, I'll have to ask you the question, how important is a properly designed incision in these small pupils, particularly in a floppy iris?
Sir, incision play a good role. Like if we, for a iris hook, let's say, if we place the incision away from the limbus, then it will lead to tenting of the pupil, which will make the surgery more difficult. So we have to make incision near to the posterior limbus. And also,
Go ahead,
it
go
should
ahead.
be triplanar.
Okay, I'm talking about that, agreed about the incision you make for the hooks. The
Yes,
main
yes.
incision itself, the incision that you make for the phaco, the main incision that you make for the side port to use the chopper, is that critical, and why is it, if it is? Okay,
The
I'll tell
main
you.
wound should be triplanar,
Yes,
so that it will be self-sealing, and iris will not come out again and again during the surgery, to prevent iris prolapse also.
excellent. Iris prolapse would occur if it's a poorly designed wound, if it
Yes,
is
sir.
too large and there's a lot of leak. So the wound should be of the appropriate width and also long enough, at least 1.25 millimeters long, if not longer than that, to make sure that you do not get an iris prolapse through the main port during surgery. It also is very important to make an appropriately sized side port too. If that leaks a lot, the iris will try to come out through that, and that would cause a lot of other issues. So it's very critical that you design your incisions very precisely. Of course, what you mentioned is absolutely correct, that when you make the incision for the hooks, they have to be pointed downwards and not a lamellar incision through the cornea. Agreed.
Thank you, sir. Dr. Sudeepta, ma'am.
Yeah, first of all, Mehak, it was a nice presentation. As Dr. Titial correctly mentioned, you could have added the indications, etc., and that would make your presentation complete. Now, for a small question, when will you decide to put in the hooks, at any stage of surgery or at the beginning, or what is the minimum size of the pupil when you decide to use your expanding device? Can you tell me?
Sir, ma'am, as such, we can use at any stage, but mostly people prefer it before the rexus, but we can use it in any stage.
Agree. You as soon as you feel uncomfortable that you cannot go on, especially with IFIS, you should always use your people expanding device to be safe. And very well mentioned, Dr. Arun Muzija, sir, that you have to have a very good wound construction. I would also like to mention that you should have good dynamics, because if there is a lot of turbulence in the anterior chamber, then a surgery will go haywire and your pupil expand devices may not work as required. Thank you so much.
Thank you.
Thank you so much, ma'am. Thank you, team Dread Drucinoids. Good presentation. Now, I would like to invite their mentor, Dr. Kirti Singh, ma'am, to give her comments and encourage her team.
So thank you, YOSI. And it's a pleasure to hear your students present so well. And it's always a pleasure to hear the other questions also come in. So it's a very great effort. And let me tell you that the student is just finished first year. So it's a very young student who is presenting the first year residency. And she's just in the second year now. And I can just say great presentation and good luck to everyone. Thank you.
Thank you so much, ma'am, for joining us. Thank you, ma'am. Now we'll move on to our next team, which is Oculus Curatio, who will be presenting on ocular viscosurgical devices.
Am I audible?
Yes, you are.
Yes, you are.
Can I start?
Start.
Okay. Good afternoon, everyone. Our team Oculus Curatio is here to present on ophthalmic viscosurgical devices. So since our hospital is from Karnataka and this is one of the monuments from Hampi, you can see dome-shaped structures with pillars supporting them. So in our eye, similarly, the dome represents the cornea and the pillars are the OVDs during surgery. So what are viscoelastics? Viscoelastics are a class of non-active clear gel-like chemical compounds with viscous and elastic properties. And they are viscous liquids and elastic solids. So what is an ideal OVD? An ideal OVD should be viscous enough to prevent AC collapse, liquid enough to be injected through a small cannula, should have coating properties, and cohesive enough to be removed easily. So let us look at the rheological properties of the viscoelastics. First is the viscosity, which is the resistance of the solution to its flow, which is determined by its molecular weight and concentration. So higher the viscosity, it will be difficult to displace the viscoelastic device and it will move the tissues more effectively. Pseudoplasticity is the property by which substances change their viscosity with the shear rate. A substance with greater pseudoplasticity will move more easily through a small cannula and it will be easier to remove from the AC. Coatability is equivalent to the lubricating power and it is determined by the surface tension and contact angle. So higher coatability means lower the contact angle, lower surface tension and more negatively charged OVDs. And chondroitin sulfate has better coatability. Now let us see cohesiveness. Cohesiveness is degree to which the material adheres to itself, and dispersiveness means the tendency of the material to disperse when injected into the AC. Viscoelasticity is the ability of the material to retain its original shape after deformation, and in cataract surgery, basically there is a lot of manipulation going on in the anterior chamber, and this property helps in maintaining the AC structure. Classified into cohesive, dispersive, and viscoadaptive OVDs. Cohesive OVDs have high molecular weight, they have high viscosity, they deepen AC and sustain pressure. They help in enlarging small pupils, dissect adhesions for IOL implantation, and also used in soft shell technique, but they have a high risk of increasing the IOP. Dispersive OVDs are low molecular weight, they have excellent coating, provide endothelial protection, but they do not help in maintaining the AC during surgery. Now, under high shear conditions, cohesive substances behave as spaghetti pasta. That is, when we go to remove a cohesive substance, it comes out as a whole because of its long polymer like chain-like structure, whereas dispersive OVDs act like penne pasta. That is, they do not get removed from the anterior chamber easily. Under low shear conditions, the cohesive substance, that is, whenever we are doing any stages like capsulorhexis, cohesive substances act like jelly, whereas dispersive act as honey. Viscoadaptive behavior changes as the flow rate changes. The example is Helon 5, and it is used in ultimate soft shell technique. Uses of OVDs. OVDs are used in each step, almost every step in cataract surgery, may it be rhexis, emulsification, cortex removal, or IOL insertion. So this video shows use of OVD in capsulorhexis, where we inject the OVD during capsulorhexis, and it provides a counter force while we are making the rhexis. This is soft shell technique in which we use cohesive as well as dispersive OVD. Cohesive OVD to maintain the anterior chamber, whereas dispersive OVD to protect the endothelium. The other uses of OVDs are in cornea for buttoning, in posterior segment surgeries, in oculoplasty like in DCR and in canalicular repair, and in glaucoma surgery like trabeculectomy and viscocanelostomy. The complications of OVDs include postoperative increase in IOP, toxic anterior segment syndrome, calcific band keratopathy, crystallization of IOL surfaces, and capsular bag distension syndrome. OVDs tend to cause an early capsular bag distension syndrome due to its retention. There is a shallow AC, but IOP is normal. Treatment is usually neodymium doped gas posterior capsulotomy to allow OVD to escape posteriorly, or we can go for pars plana vitrectomy. These are my references. Thank you.
Great presentation. I feel
Thank
very
you.
hungry now seeing penne pasta, spaghetti pasta, and jelly and honey. Can you stop sharing, please?
Yes.
Now I would like to invite Dr. Arul Moli, sir, for his comments and questions.
Yeah, I'll ask the first question.
Yes, sir.
You have a patient who's got a well-dilating pupil, fairly hard cataract. Endothelium is
Yes, sir.
not too good. It's not really bad, but it's not a very healthy endothelium.
Yes.
Now, exactly what would you do in each step of surgery? First, when you start your surgery, when you proceed 2, as you start doing phacoemulsification, and 3, what would you do when you implant the lens? As far as this is question asked with respect to your OVDs.
Sir,
How do you-
since the endothelium, there is decompensation, as you said, there is slight decompensation. We would like to use dispersive OVD to coat the endothelium first. While making a rhexis, we will also use a cohesive OVD so that the rhexis is completed and it can provide a counter force. While nucleus delivery, what we can do is if we are going for phaco, then we can use something called as the soft shell technique. That is, we can use dispersive OVD to coat the endothelium and cohesive OVD to maintain the AC. And suppose if we are going for SICS and if we are going for nucleus prolapse, then we have to use dispersive OVD as there is a lot of endothelial touch. So we have to use a copious amount of dispersive OVD so that the endothelium decompensation, endothelial damage is less.
IOL implantation?
During IOL implantation, sir, we'll have to use a cohesive OVD so that it can fill the bag, and then IOL insertion is also easy, and dispersive OVD as well.
No.
We can also go for, sir, visco-adaptive OVD like Helon 5.
Okay, you covered everything, but you haven't got it in a sequence. A soft shell technique would be indicated because the endothelium is a little off and you want to have good protection and you want to be able to do the rhexis. So you put in the dispersive.
Yes.
Fine. But when you're doing the phaco, yes, you need endothelium to be coated completely. When you put in the IOL, you want to use a cohesive because it'll expand the bag, the lens goes in. When you do IA, it comes out entirely, easily comes out. So that's the way to go. One final question, do you still get Helon 5 in India? I haven't found it for 3 years. So if you're able to get it, I really like to know where you can get it.
Sir, I'm not sure.
For 3 years, it's not been available. It's a fabulous product. You did not mention the viscoadaptiveness. Helon 5 is very high molecular weight, very long chains. It will behave both like the cohesive and a dispersive. When you try to take it out, though it is long chain, the chain breaks up. So the coating remains for a long time. It starts to behave into break up and then comes out very slowly. So one of the issues about using viscoadaptive is that you have to spend a lot of time evacuating the anterior chamber end of surgery. Otherwise, it's retained and will cause a huge IOP rise postoperatively. Thank you.
Thank you, sir. Dr. Tityal, sir.
First of all, Dr. Uttara, very nicely compiled talk on viscoadaptive device.
Thank you, sir.
One thing I like to, because you have named so many devices. What are the sources of these devices? Let's presume one, sodium hyaluronate. What are the sources for this? From where these we get?
Sir, initially, historically, sodium hyaluronate was separated from the vitreous itself. Chondroitin sulfate,
Now we are using as an intraocular surgery. What are the actual source of these?
So chondroitin sulfate is isolated from fish cartilage.
What was sodium hyaluronate?
Sorry, sir.
What about the sodium hyaluronate? Sources. Okay. You mentioned, soft shell technique. Who was a person who described this?
Dr. Arshinov, he described it.
Okay. He also talks about, triple soft shell technique. What is that?
So triple soft shell technique, we use 3 components. First is the visco adaptive component. Then is the dispersive OVD, and third is the balanced salt solution.
Okay,
So
why these OBDs are not colored? Because they are all transparent, it's difficult to see. can they be colored so that you can see how much are left and how much you removed?
Sir, we can use tryptophan blue to maybe stain and see the.
Methyl cellulose may get stained, but not others. Because viscose and dispersive one is totally oily, nothing gets stuck stained. But you can see the chords. If you have very high magnification, good retroillumination, you might see them. But still, you leave so much amount of viscoelastic, which is difficult to remove and cause post-op, high IOP in these cases. But yes, nice presentation, Uttara.
Thank you. Thank you, sir.
Thank you, sir.
Dr.
Thank you.
Parikshit, sir.
No, I think Dr. Titial has asked all of it. Thank you.
Thank you, sir. Dr. Sudeepta, ma'am.
Nothing much to add. I would like to just add on or actually ask a question. So, is there a role of your viscoelastics when there is a PC rate?
Yes, ma'am. We can use dispersive OVDs in case of PC rent. Usually, if there is a intact PC, we usually see the toothpaste sign that is there. That is one of the signs that we can see. But in case of a PC dehiscence, that won't be seen. So maybe we can insert the dispersive OVD and see.
The first thing that we usually do if there is a tear is before withdrawing our cannula, we push in some amount of viscoelastics so that your anterior chamber does not collapse. Just mentioned earlier in another case that it is very important to maintain your chamber stability in these cases also, just like post-polar cataract. And since there is a PC dehiscence. And secondly, it helps to plug if there is one point, there is a tear or a bit of subluxation, the OVD helps to plug that place so that furthermore it does not increase. Otherwise, the presentation is very nice. The answering is also very good. Congratulations.
Thank you, ma'am.
Thank you, ma'am. Now I would like to invite Dr. Guru Prasad, sir, mentor of Team Oculus Curatio, to give his.
Thank you for this opportunity. First of all, I would like to say that I'm humbled by participating in this program where there are luminaries in the Indian ophthalmology. And also, it's very heartening to note that our young ophthalmologists, budding ophthalmologists, just in the first year or just completing first year, are doing so well, presenting so well. Am I heard?
Yes, sir.
Okay. So the moderator seems to be looking away. I thought I'm not heard. So what I was saying was that these students are extremely good and presenting extremely well, and it's really heartening to note that the future of the country is doing so well, and the future patients of our country are in good hands. So thank you for Dr. Nupur for putting up a very good Nupur Goyal for putting up a very good YOSI iROCK session this afternoon. And congratulations to all the participants, the students, and all the best for the next coming sessions in the next hour or so. Thank you once again.
Thank you, sir.
Thank you so much, sir, for joining us. Thank you, sir. Now I would like to invite the last. I would like to invite SNMC iStars to present the last presentation of the first round, which is on phakodynamics.
Ma'am, is my screen visible?
It is. Please begin with the first slide.
Your first slide,
I
right?
assume this is your third one. Yeah, okay. The time
First
starts now.
Good evening, everyone. My topic is phakodynamics. Phacoemulsification main goal is to remove cataract through small incision and to achieve rapid visual rehabilitation. What is phakodynamics? The various functions of phaco machine and their interrelationship is called phakodynamics. Dr. Barry Sibyl was first to use this term. We'll study phakodynamics under ultrasound energy and fluidics. Very important to know your machine. Phaco machine consists of computerized ultrasound system, phaco handpiece, foot pedal, irrigation aspiration, pump system. Handpiece has 3 connecting lines, one for irrigation, aspiration, and ultrasound energy. Phaco tip is made up of hollow titanium needle which can be bent at various angles. Phaco sleeves are made of silicon material. They provide cooling effect. Parameters mentioned on the screen include aspiration flow rate, vacuum, and power. Aspiration flow rate is how fast materials come to tip. Vacuum is amount of holding power of your Phaco tip. Power is ability of Phaco handpiece to cut and emulsify cataract. There are 3 foot pedal position. First is for irrigation, which is static. Second is for irrigation and aspiration. Third for irrigation, aspiration, and ultrasound power, which are incremental. Power, the energy used to emulsify the lens. Piezoelectric crystals turn electrical energy into mechanical energy. Power is created by interaction between frequency and stroke length. We can vary stroke length. Frequency is fixed for the machines. Frequency is how fast tip moves, and stroke length is how far the tip moves. For each machine, stroke length is variable and frequency is fixed. There are 3 ways in which tip moves: longitudinal, torsional, transverse, or elliptical. Mechanism by which Phaco works: jackhammer effect, direct mechanical effect, cavitational by implosion of microbubbles, acoustic wave. There are 3 modes: Phaco mode, which is continuous mode, all time ultrasound is on, there is no off time. Its disadvantages is that there is more power delivery. Pulse mode, power is not delivered throughout, on and off time present, it is same throughout. Advantages, it gives less power. Pulse mode, it presents as 2 pulses per second. We can adjust the pulses. Duty cycle is time during which Phaco is on as by total time of the cycle. Burst mode, pulse is not delivered throughout, on and on time is present but not same. At the end, it is same as continuous mode. There are 2 new modes: hyperpulse mode, linear mode with more off time, and hyperburst mode, in which burst width is 4 milliseconds. Normally burst width is 30 milliseconds. Now fluidics, irrigation source is a bottle of BSS, aspiration fluid by Phaco probe, and leakage through incision. Aspiration, low aspiration flow rate, materials will come to tip slowly. Aspiration high, material will come quickly to tip. There are 2 pumps: peristaltic pumps and venturi pumps. In peristaltic pumps, vacuum is created by pinching of tube, and in venturi pumps, vacuum is created by Bernoulli's principle by passage of compressed gas. Rachel et al. Compared the two and found that Phaco tip in-out time was less for venturi pump, and it is better efficient, while complication rate was same. Diaphragm pumps, it works same as venturi pump. Vacuum is created by movable diaphragm. Vacuum is holding power to keep nuclear fragment to tip. Higher is the vacuum, higher is the holding power. Compliance of tubing, more compliant is the tubing, tendency to collapse is more. Low compliant rigid tube, less tendency to collapse. Rise time is the amount of time required to reach maximum preset vacuum, assuming complete tip occlusion. Followability is tendency of nuclear fragments and cortical matter to come to tip. Surge, when Phaco needle is occluded, tubing collapse due to negative pressure, and when occlusion breaks, fluid is sucked into Phaco tube, leading to shallowing of AC. Surge occur when outflow is more than inflow. How to reduce surge? Low AFR and vacuum, increase bottle height, use non-compliant tubing, venting, ABS system, or reduce tip size. Applications: in sculpting, we need more aspiration flow rate. For chopping, we need more holding power, so vacuum should be more. And for quadrant removal, aspiration and vacuum both should be more. Take home message: using Phaco power modulation and judicious use of irrigation and aspiration, it is possible to reduce Phaco time and energy. It can make surgery faster, quick post-operative visual recovery. And also now is the time for intelligent Phaco that senses the vacuum and provide energy. Thank you.
Thank you. Thank you. Great presentation. Can you please stop sharing?
Yes.
Yeah, thank you. And now I would like to invite Dr. Titial sir to give his questions and comments.
First of all, it's very difficult to cover this topic in 5 minutes.
Yes, sir.
No one can do that, And she was rushing through the presentations, And unfortunately, this is a topic which is sometimes very difficult to understand also, because each part can be, for 1 hour you can speak and still people may not understand, because this has the values has to be practically appreciated by the surgeon himself or herself also. But you try to cover most of the things. Yes, things have changed so much. When the initial Phaco system had come in the early 90s, now in mid of this 2020, the things have changed so much. You have newer devices, newer concepts. I think basic thing you highlighted was very nice, how to decrease the energy which is required for emulsification. In that, pulse mode is now appreciated by most of the systems, where you can combine pulse with longitudinal system. You have a torsional system has come, which has made life simpler for many surgeons. But ultimately, it is the technique used by the surgeon effectively, which makes a huge difference, because all the machines have come with the better systems now. And one thing you should have highlighted more on our occlusion surge, post-occlusion surge, how we prevent that, which are the various other systems to vent out, like venting systems for post-occlusion surge to avoid. And the newer things, which is as you talked about if you look into your fluidics part, so you have now gravity related fluidics and the IOP related, which is called active fluidics. So that has to be highlighted also. But basic part you covered very nicely, and I don't think any question can be asked in such a short presentation or such a large topic. Yeah.
Sir, I was having slides on ABS also, but there was no time to mention that.
Thank you. Thank you, sir. Dr. Sudipta, ma'am.
Yeah, again, it was a great presentation, and very correctly, there's lots and lots to be discussed over time in different situations. And but I think you did quite a good justice you on your presentation. It's very difficult to ask anything. Yes, the last part, the active fluidics that you, Dr. Pritial mentioned, that you should have in mind. You should always, because that's a recent part that is coming, and with that, the pharmacodynamics has changed a lot. The surgical time, the outcomes, they have changed a lot, and we can now operate in all type of eyes with any type of IOP, and getting good results. So that part, but I think you did good justice. You covered quite a lot. So thank you, and
Thank you, ma'am.
congratulations for presenting.
Thank you, ma'am. Dr. Parikshit, sir.
No, Dr. Akshay, I mean, all the stalwarts in FACO have said they have congratulated you. Just one small question. We have now so many options. You mentioned pulse, then hyperpulse burst. For which kind of cataract, types of cataract, would you want to use these options?
Sir, for soft cataracts, we'll prefer less energy. For hard cataracts, we'll prefer more modes with more energy. Like continuous mode, we mainly prefer for hard cataracts. For soft cataracts, we prefer pulse mode, burst mode.
Okay.
Thank you, sir. Dr. Arul Moli, sir.
Yeah, I would ask the same question. Actually, your answer was a little wrong there. You don't use continuous mode, definitely not for hard cataracts, because that would make the energy used very high.
Thermal damage.
So you would always use pulse. I'll ask the question other way around. Is there a difference between a pulse mode and a micro pulse mode? What is
In
the
micro pulse mode, it is for shorter duration.
Excellent.
And more number of pulses are more in that. So it decreases thermal energy. So now we use term for cold phaco for it.
Excellent. That's important. So we all now actually use basically micropulse. On top of micropulse, it could be pulsed again. So almost no machine gives you continuous mode anymore. Everything is micropulse. So please remember, micropulsing, one other point I'd just like to pass on to you. Keep the pulses, each pulse less than 40 milliseconds. If you exceed 40 milliseconds, the micropulse can also heat up again. Keep the duty cycle at 60%, never above 80%, and micropulse with the on time to be at 40 milliseconds or lesser. So that you're tuned, look at this, which suits which cataract. And you'll have to tune it according to that particular phaco machine that you're using. That's a very good presentation. Thank you.
Thank you, sir.
Thank you. Thank you so much, sir, for the comments. Now I would like to invite the mentor of team SNMC iStars, Dr. Arvind Chauhan, sir.
Good morning, sir. This is nice presentation from the Dr. Akshika, and we use the machine, the Hartley machine, and this machine has all the pulse mode, and we did the out cataract with the pulse mode.
Who did this?
Thank you, sir.
Thank you. Thank you. Thank you so much, sir. Thank you to all the presenters. Now we'll move on to the next round. I would like to invite Dr. Ritu to moderate the next session.
Thank you, Dr. Samir. I'm pretty sure the judges would love to see how these talented residents have an out-of-box idea to present as well. The second round here is Pupils Got Talent. Next slide, please. These are the rules for round 2. Each team member will collaborate to give a creative presentation in any form, like reels, music, dance. So they'll be given 20 marks for each presentation. And today's theme, as you all know, is cataract. Next, please. Team 1, Dr. Samir will be presenting the slide from his slide.
आंख में चोट लग गई है, बहुत दर्द हो रहा है, दिखाई भी नहीं दे रहा कुछ।
डॉक्टर साहब कुछ साल पहले इसकी दूसरी आंख में भी चोट लगी थी, जिसका ऑपरेशन भी हुआ था।
देखिए, यदि आपकी पहले भी चोट लगी हुई है दूसरी आंख में, तो और जिम्मेदारी आपकी बनती है कि आप इस आंख का बचाव करें। ऐसी स्थिति में दूसरी आंख में भी दिक्कत फैलने का खतरा रहता है, इसलिए बहुत जरूरी है कि दूसरी आंख का बचाव किया जाए। यदि आप कोई ऐसा काम करते हैं जिसमें आपको चोट लगने का खतरा है, तो उसमें आपको प्रोटेक्टिव गियर पहनना बहुत जरूरी है। शील्ड पहनिए, प्रोटेक्टिव ग्लासेस पहनिए, हेलमेट पहनिए, और सारे ऐसे खेल ना खेलिए जिनमें आंख में चोट लगने का खतरा है। ऐसी स्थिति में डॉक्टर और पेशेंट दोनों की काफी जिम्मेदारी है दूसरी आंख को बचाने की, ताकि दिक्कत दूसरी आंख में ना फैले। डॉक्टर को पेशेंट को समझाना बहुत जरूरी है और पेशेंट को अपनी आंख का बचाव करना चाहिए।
डॉक्टर साहब 2 हफ्ते से मेरी इस आंख में दर्द हो रहा है, आंख लाल भी पड़ गई है और देखने में भी दिक्कत हो रही है।
डॉक्टर साहब कुछ साल पहले भी इसकी दूसरी आंख में चोट लगी थी, जिसका ऑपरेशन हुआ था, और अभी कुछ सप्ताह पहले इसकी आंख में लाली पानी आया कुछ थोड़ा, तो हमने बाजार से लेके कुछ दवाइयाँ इसकी आंखों में डाल दी, लेकिन सोचे कि सही हो जाएगी, लेकिन कोई आराम नहीं मिला अभी तक इसको।
देखिए, सबसे पहले तो अगर आंख में कभी भी कोई दिक्कत होती है, तो अपनी मर्जी से बाजार से दवाई लेकर नहीं लाना होती है। आपको नहीं पता कि वो दवाई किस चीज की है। अगर आंख में पहले कभी चोट लगी हुई होती है, तो दूसरी आंख में भी उस दिक्कत के फैलने का खतरा रहता है। इस कंडीशन को हम लोग सिंपैथेटिक ऑप्थेल्माइटिस कहते हैं, और इसमें दूसरी आंख की रोशनी जाने का भी खतरा रहता है। इसलिए ये बहुत जरूरी है कि अगर आप अपनी आंख में कुछ ऐसा चीज महसूस कर रहे हो कि लाली पड़ रही है या फिर देखने में दिक्कत हो रही है, और पहले कभी चोट की हिस्ट्री है आपकी, तो तुरंत अस्पताल आए, तुरंत डॉक्टर को दिखाएं। ऐसी स्थिति में डॉक्टर की भी काफी जिम्मेदारी है कि वो पेशेंट को समझाएं कि दूसरी आंख का बचाव करना है, और ऐसे लक्षण देखने पर तुरंत अस्पताल आकर डॉक्टर को दिखाना है। सावधान रहें, सुरक्षित रहें।
Very well presented, team luminescence. Do we have Dr. Tityal, sir? I lost him, I guess. Yes.
Yeah, I'm there.
Any comments? Yes, sir.
Good try. I think, one thing I would have liked was the background. Whenever you are trying to give something, it was a very blank background which was not reflecting anything. If it would have been a OPD area or in front of a slit lamp or something like that, would have given a true picture of the hospital surrounding and would have been more attractive. So whenever you record such type of thing, the background should be as required, which can have a more attention of a people listening to a doctor. So that was one missing in this. And second was, two very nice points were taken up. How things can be prevented, but it could have been made, expression from the people who are complaining also. Once the doctor explains, okay, you should do like this, the person who had complained should say, okay, doctor, I've understood, I'll do this. So that would have made a little better impact on this.
Thank you so much, sir.
Yeah.
Dr. Parikshit, sir.
No, they showed it very well. They could also have shown a few personal protective devices for people to, something that can be actually used whenever they are doing something which is risky. But very well done.
Thank you, sir. So, Dr. Arun Morisa, how did the team illuminate us?
Yeah, that was nice. Quite nice. As told by other two judges, the background could have been a hospital or something more professional that would have been more convincing, and other protection devices can be just shown as an advice, but otherwise nice.
Thank you so much, sir. In the interest of time, I'll have to move to the next team. Team Gladiators. Here's their presentation.
Finding the right fit for your eyes.
Welcome, welcome.
A renowned headmaster came to our hospital. Let's see who.
Hey Professor, why are you wearing 3 pairs of glasses?
I'm 150 years old, doctor. One is for distance, one is for near, and one is for style.
Good news, Professor. You need a cataract surgery. And after removing the cataract, we can place either a monofocal or a multifocal lens.
How is that possible? We weren't taught that in our charms classes. Can muggles do magic?
Well, you thought only wizards could do magic? So, we have a monofocal where you get to keep your reading glasses and you'll be able to see clearly at a distance.
And what if I want to ditch the glasses?
We have magic for that too. Multifocal. You won't need any glasses, but it'll take time to adjust. And you might experience glare.
Well, I've been experiencing glare through the enemy wands my entire life. I think I'll be able to handle it.
After the cataract surgery, our professor could read books, won wars, and could cast all his spells sharply.
To summarize, I've been reading books of old, the legends and the myths. I can see clearly all I want. These lenses I'm happy with.
The choice is yours.
Choose the right IOL. The IOL that suits your lifestyle. For a clearer tomorrow.
Very well presented. A glaring Dumbledore, and we had a cross mashup of Coldplay as well. Yes, Dr. Sudeepta ma'am, do you have any comments?
Yeah, first of all, very innovative, very creative, very nice. Congratulations. Nice acting. And your message also comes quite straight to this thing that to get freedom from classes or whatever, like choosing the right lifestyle. Well, I don't want to ask any questions or comments. Nice one. Carry
Thank
on.
you so much, ma'am. Dr. Arunmoli, sir?
Oh, that was really very nice, very interesting concept, done excellently. That should congratulate the team.
Thank you so much, sir. The
Thank you,
pupils
sir.
indeed have got talent.
I would have appreciated the last picture. There should have been 3 people there, you know. It was only bifocal. There's no trifocality in that. So you should have had a taller person made at this, and that would have given a trifocality in the presentation also.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Next team. Yes, team 3, the dreaded drucinoids.
क्या डॉक्टर साहब इससे दूर का ही दिखता है, पास का तो बिल्कुल ही कुछ नहीं दिखता है। पहले कम से कम पास का दिख तो रहा था, अब तो काम ही नहीं कर पाती हूँ पास का। मेरे भाई की भी गलत है लेंस, उसको तो दूर पास दोनों का दिखता है। आपने कैसा घटिया क्वालिटी का लेंस डाल दिया मेरी आंखों में?
अरे तुम्हें कम से कम दूर का तो दिखता है। मैं तो काला मोतिया की मरीज हूँ, इन्होंने कहा था दूर और पास दोनों का दिखेगा, और अब देखो मुझे तो ऑपरेशन से पहले ही ठीक दिखता था डॉक्टर साहब।
आज के टाइम पर जब हमारे पेशेंट्स की डिमांड्स अलग अलग है, जब हमारे पास अलग अलग टाइप के लेंस अवेलेबल है, तो हम अलग अलग टाइप के लेंस कौन से पेशेंट्स में डाल सकते हैं ताकि उनकी डिमांड्स पूरी कर सकें। आइए देखते हैं। कल आपका सफेद मोतिया का ऑपरेशन है जिसमें आपको लेंस डाला जाएगा। आप कैसा लेंस डलवाना चाहते हैं?
डॉक्टर साहब मैं एक हाउसवाइफ हूँ, मुझे दूर और पास दोनों का काम है और मैं बार बार चश्मा नहीं लगा। मैं चाहती हूँ आप ऐसा लेंस डालें जिसमें मुझे दूर और पास दोनों का दिखाएं।
क्या आपको रात को ड्राइविंग करनी पड़ती है?
नहीं।
ठीक है, आपके लिए बेहतर यही रहेगा कि आप मल्टीफोकल आईओएल डलवाएं जिसके अंदर आपको दूर का और पास का दोनों का काम चल जाएगा।
मुझे लगता है कि भी यही लेंस सही रहेगा। मुझे भी दूर और पास दोनों का काम करना पड़ता है।
आप क्या काम करते हैं?
मैं सिलाई का काम करती हूँ।
लेकिन आपके लिए वो लेंस ठीक नहीं रहेगा, वो इसलिए क्योंकि आपको काले मोतिये की दिक्कत है और आपको पर्दे में भी दिक्कत है। जब ऐसी दिक्कतें होती हैं तो ऐसे में मल्टीफोकल आईओएल के अंदर आपको हो सकता है कि कमी आए देखने में, क्योंकि कॉन्ट्रास्ट काफ़ी कम हो जाता है।
तो मैं तो सिलाई करती हूँ।
आपके लिए बेहतर यही रहेगा कि आप मोनोफोकल आईओएल डालें, जिसके अंदर सिर्फ दूर का दिखता है। पास के लिए आप चश्मा लगाएं, क्योंकि उसके अंदर कॉन्ट्रास्ट वगैरह की दिक्कतें नहीं होती।
तो डॉक्टर साहब लेकिन कभी कभी तो मुझे गाड़ी चलानी भी पड़ती है।
अगर आपको कभी कभी गाड़ी चलानी पड़ती है, रात के अंदर आपको बेटर यही रहेगा कि आप ईड ऑफ लेंस डलवाएं, यानी एक्सटेंडेड डेप्थ ऑफ फोकस लेंस। ऐसे के अंदर आपको दूर का अच्छा दिखता है, पास का भी कुछ हद तक दिखता है, लेकिन बिल्कुल पास के बारीक अक्षर के लिए आपको चश्मा लगाना ही होगा।
ठीक है, तो वो ज़्यादा बेहतर है।
जी।
Thank you, team. Remove the dreads of both the patients. Yes, Dr. Parikshit sir, do you have any comments?
No, after seeing a lot of gizmos of the earlier team, this seemed a bit bland, but they did put forth about presbyopic individuals, about individuals who do outdoor activities, and individuals who have other ocular comorbidities like glaucoma. So they did put it very well. If there would have been, say, more color or more drama, perhaps that would have helped, but the content was good.
Thank you, sir. So, Dr. Titial sir.
No comments. It was a good try, and at least the discussion was better. I think understanding to the person. Only thing I would have liked, to have a one dialogue. Okay, for a counseling, one thing is important. The person should understand what we are talking. So language could be a one. If they would have spoken a different language also to two people, one in Hindi, one in Punjabi, or one in Udiya, something like that, that would have given a more impact. Because understanding language is also very important in the counseling.
Thank you, sir. The participants are indeed receiving such fruitful comments. Team 4, slight change.
India's undeniable economic growth has coexisted with substantial segment of population grappling with basic necessities. Despite nationwide provision of free universal health care, a significant lack of access to essential care, particularly eye care, persists due to limited awareness. 6.4 million people in India suffer from cataract-related visual impairment, which accounts for approximately 50 to 60% of blindness in India. So what is cataract? Cataract is age-related clouding of the lens that affects vision and usually occurs after the age of 50. Its symptoms include blurring of vision, double vision, sensitivity to light, and difficulty in seeing at night. It is diagnosed by a simple torchlight examination or a slit lamp examination by an ophthalmologist. The treatment option is only surgery by removal of the cataractous lens and replacing it with an artificial lens. The community camps play a pivotal role in addressing cataracts, particularly in rural or under-reserved areas. The benefits are early detection, awareness and education, surgical intervention by offering free surgeries or at subsidized rates, and follow-up care. The community camps are impactful as they reach the grassroots level and help in detecting of cataracts. Also, there is reduced waiting time as they can enable patients to receive timely treatment. There are improved outcomes as patients receive proper care and follow-up services. Also, they are cost-effective for reducing the financial burden on patients and the healthcare systems. So by addressing the challenges and barriers faced by underprivileged communities, we can work towards reducing the burden of cataract, which is a cause of preventable blindness, and improving eye health outcomes for all.
Very informative session. For every layman, I would say, we can just forward this on YouTube. Dr. Sudeepta ma'am, please share your comments.
I actually say the same that you say. It is very informative, loaded with information, very nicely curated. All the presentations, how you look at the slit lamp and all, is very realistic in an atmosphere how they've done it. So this will go a long way in sending information to the patient and a common man as well. So well done.
Thank you, ma'am. Dr. Arun Modi, sir.
Yeah, very well done clip. It just it tells the importance of social outreach in eye care, particularly in a country like ours, where we have a large number of cataract population that's underserved. It's very, very useful, very nice. As you said, this can just go on the YouTube and be of useful to the general public.
Thank you, sir. We'll move to the last.
India's.
Yes, SNMC stars.
चलो फ्यूचर डॉक्टर्स इधर आओ। आज मैं तुम लोगों को फेको डायनामिक्स के बारे में एक मजेदार कहानी सुनाने वाला हूँ। सोचो तुम एक बहादुर नाइट हो और तुम्हारा मिशन है किंगडम को बुरे कैटरेक्ट ड्रैगन से बचाना। सबसे पहले मिलो तुम्हारी जादुई तलवार से, फेकोइमल्सिफिकेशन प्रोब। ये कोई आम तलवार नहीं है, ये अल्ट्रासोनिक है। इसके वाइब्रेशन से ये कड़े कैटरेक्ट को छोटे छोटे टुकड़ों में तोड़ सकता है। लेकिन रुको, ऐसे ही नहीं चलाना है। अब आता है सीक्रेट सॉस फ्लूइड डायनामिक्स। इसे ऐसे समझो जैसे किंगडम में एक नदी बह रही है। सब कुछ स्मूथ और सेफ रखने के लिए तुम्हें सही अमाउंट में फ्लूइड चाहिए। ज्यादा हुआ तो नदी ओवरफ्लो हो जाएगी और सब गड़बड़ हो जाएगा। कम हुआ तो नदी सूख जाएगी और तुम्हारी तलवार फंस जाएगी। फिर है जादुई शील्ड इरिगेशन और एस्पिरेशन सिस्टम। ये बैटलफील्ड को साफ रखता है, टूटे हुए कैटरेक्ट के टुकड़ों को चूस लेता है और आंख का प्रेशर बैलेंस्ड रखता है। ये सब फिनिशिंग का कमाल है फ्यूचर नाइट्स। याद रखो, कैटरेक्ट ड्रैगन को हराने का की है। हल्के हाथ और परफेक्ट कंट्रोल। फेको डायनामिक्स सीखना एक प्राचीन कला सीखने जैसा है। इसमें प्रैक्टिस, पेशेंस और प्रेसिशन चाहिए। तो अपनी तलवारें तेज रखो और अपनी नदियों को स्मूथली बहने दो।
Thank you, Team SNMC. I'll be expecting more seasons and episodes of this Night Warriors. Yes. Sir, Titial, sir. Titial, sir, do we have him here? Yes, sir. Please.
I think a good animation put in, just to have some excitement to the people, you know. But ultimately, you know, it is the how people run it. Pharmacodynamics is to understand, but actually how it is applied to the patient's benefit with your foot, hand-eye coordination, that is important. So whenever we talk about pharmacodynamics, it becomes a very theoretical appreciation, which was trying to translate into a more practical way. But there should have been some sort of other modification where actually things should move inside the, you know, any device which tells you that things are moving inside. That would have made this presentation more, appealing.
Thank you, sir. Dr. Parikshit, sir, few words.
No, I'm speechless. I mean, it's I think it's done well considering they are first year students. And of course, pharmacodynamics is very deep, very complex, as Titi also said, and it will need a lot more polishing. But I think excellent. I'm speechless.
Thank you so much, sir. We're gonna take some animation tutorials from these kids, the new generation ophthalmologists, to be ophthalmologists. Thank you. We'll move to the last two rounds. Dr. Roma, I invite you.
Chalo,
future. One can, yeah.
I would like to invite Dr. Nupur Goyal ma'am to give her vote of thanks and facilitate the judges.
Thank you, respected judges. It's an honor, for us, for YOSI, to have you all today, sparing your valuable time and each and every comment that you gave, especially, to all the residents. I must also, thank all the residents that at this level, you're taking such efforts, you're having this courage to come and present in front of all the stalwarts. So that itself is a big thing, and congratulations to you all for that. And judges, thank you so much. I'm really, it's so heartwarming to receive all the comments from you, even those teaching points and those critical points about how they can improve the presentations will help all the residents so much. Thank you so much to all the judges you've joined us today. Quick, word of comment from each of you about what was your, what did you think about the session, about these two rounds? We can start with Tatyal, sir, quickly. If you can just give, a few words of whatever your whole, what do you think about the whole session? So
First of all, this is the, right, attitude from, YOSI to take the younger people together and bring them to a forum where they can, showcase their talent. Because it is, it is the duty of, teachers like us to make them confident confidence is the only one thing which I like to have from my colleagues and students, and that will only come by when they express themselves. And this is a platform you are given to express these people and opportunity to discuss things. And as far we are concerned, we are always delighted to listen to younger people because they are the future. They are brighter than us, and they have a more knowledge and more innovative ideas. Ultimately, innovation has to be there, and I'm pretty sure you people will do it, and we'll be in a safe hands for the future also. And today's presentation, I'm pretty sure they'll improve. And one request to people who are mentoring them to have a one session with these students, try to think how it can be made better. And I think that will have a significant input which we like from mentors. Yeah. Thank you for getting me into this program. Thank you.
Thank you, sir. Thank you so much, sir. Dr. Arul Mosi, sir, any words of your
Of course, it's heartening to see the quality that comes out of people that are young or just into residency, 1 year, 2 years. That's fantastic. That's something that we see all over the country. This is something very heartening. If this is the quality of students who are coming up now, I'm looking forward to the quality of ophthalmology a decade from now in India will just explode. It just go to places that we can't imagine. So I'm really heartened to see this quality and this understanding and this kind of effort and the creativity that is going on. It's a lot of interesting things that are coming from youngsters, and all kudos to them.
Thank you, sir. Thank you for those kind words. Dr. Parikshit, sir, any words from you, sir?
I think I again share the sentiments of both the seniors. It is really heartening to see first years have so much of creativity, so much of enthusiasm, and also so much of knowledge. And I would like to congratulate Dr. Nupur, all of you, and the YOSI team to think of this and to get the first year residents to do that. Because that is something, people generally do it in the last year of their residency or when they are doing their dissertation or submitting their dissertation. And some of this very, very basic, but then this is something that is bread and butter for most of us who are present over here. So excellent. And thank you again for having me on board.
Thank you, sir. Dr. Sudipta, ma'am, any comments from you?
Yes, only one word. Wow. Not only are the presentations great, first of all, I would congratulate Yosi for thinking of this. It's really great. And thank you for inviting me in this session, because if learning is both ways, then if they have shared something, I have learned how to be more creative. So thank you so much. And it is really, really, I'm delighted with the way they're coming up, the courage, the confidence they are showing. Learning is a process, so you go on learning regularly, upgrading yourself. But the way you're bringing them together and they're getting this access, I congratulate each one of you for that. Thank you so much. And may this go on.
Thank you to all the judges. And I would just like to point out, that this idea of YOSI iROCK was actually our YOSI president, Dr. Divakan Misra's idea. He wanted something, so we could have something like this. We just put it to execution, and the whole team of, YOSI iROCK, the moderators, Sudhira, Sameer, Roma, and Dr. Ritu, but the whole team, the 15-member team has been working very hard since the last 3-4 months, making the quiz questions, charting out all the sessions. So it's what you're seeing today is an entire teamwork. And we are really thankful to the judges once again. And we have 2 more rounds pending, so our judges are more than welcome to stay back. But we know that, we have taken up a lot of your time. So it's up to you. We would be very happy if you could stay back. And just small token of appreciation from Yossi to, from us to you. These certificates, we'll be sending this on the WhatsApp group as well. So thank you, Dr. Tityal, sir, for your inputs today. Dr. Arul Mosi, sir, Dr. Parikshit, sir, and Dr. Sudipta, ma'am, for your, it was really, your heartwarming, very heartwarming to have you all here, and all your comments and invaluable comments about everything. Thank you so much. And before we move on to the next 2 rounds, I'll also request everyone to quickly turn on their video, and we can have a quick screenshot with our esteemed judges. All the team members, if you all can, quickly turn on the videos as well. And Mr. Sai, Miss Manjula, if you can just help us with the screenshot. Yeah, Manjula, you there? Yeah. Samir, can you take the
Sai
screenshot?
and Manju are always there in the
Yes,
background.
you are there. Yeah. Samir, can you take the screenshot for us?
Done, doctor.
Thank you.
Thank
So we
you.
can have one with the YOSI sign, everybody. Arun Mosi sir, Tatyal sir, we have this YOSI sign. If we can just do this and yeah. Manjula done? Yeah.
Thank you.
Yes, doctor.
Thank you.
Thank you.
Thank you.
Thank you so much, sir and ma'am.
Yeah, and just share the Excel sheet with Samir and we'll
Yes.
announce the results by
Sir has already shared,
Yes.
and we request other judges as well to share the Excel sheet.
We'll do that. We'll do that.
Thank you.
Now, I would like Roma ma'am. Can you please share your screen?
Doctor, shall I stop the stream, doctor?
No, we still have two more.
Manjula, 2 more rounds are left.
Okay. Sorry, doctor.
Yeah,
Sorry.
this is just the
Hi, Samir. Can you hear me? Now, can you see the screen?
Yes, ma'am. Can you please go in
Okay.
slide?
Yeah. After the wonderful presentation and discussion, we'll move to round 3, which is our knowledge nexus quiz. So I hope everyone is ready for that. All teams will play together. We have one pre-decided team member who will attempt this round. It has 10 multi-specialty questions, and you'll be given 20 seconds to answer in the chat box. Not only with respect to your mind, but with respect to your finger also, you have to be quick. It's a fastest finger and it's like a buzzer. You have to type the team number allocated to you in the chat box. 1 is for luminescence, 2 for gladiators, 3 for dread reducens, 4 for oculus ratio, and 5 for SNMC I stars. Whoever will type their team number first will be asked to unmute and give the answers. Audience also, please stay alert and active because we have 3 audience questions, and whoever will want to attempt them first, they have to type I in the chat box and then they can unmute and answer. So they can get multiple, they can win prizes for that. So this is a trial question. I'll ask all the participants to please be ready. Where is Taj Mahal located? A, New Delhi, B, Hyderabad, C, Agra, and D, Kolkata. Okay, so team 3, can you please unmute and answer?
Ma'am, option 3, Agra.
Yeah, that's the correct answer. So now we'll go with the actual quiz. All of you, be ready. All the best.
So just wait. Roma, can you just go behind? Go back. Yeah. Okay. Wait. So we'll be typing XX in the chat box and you have to type the team number only after that. Okay. Otherwise it will be null and void. So when I tell you, Roma, to change the slide, then you change the slide. Okay.
Okay, ma'am.
Yeah. Now you go ahead, Roma. Wait.
Please do not.
Please do not. We will cancel this question otherwise. No, this question is cancelled. Go on. This question is cancelled. Yeah. Go ahead. We are not giving this. Please wait till we tell you to type. You cannot, till the question is projected, you cannot type in, please. Okay. So Roma, move on to the next question. Yeah. So the question, what was the question? You can just read out.
Identify the structures and the defect associated. A, optic tract. B,
Easy question खराब हो गया यार.
optic tract, monocular vision loss. B, optic chiasma, bitemporal hemianopia. C, optic chiasma, contralateral homonymous hemianopia. D, optic radiations leading to central scotoma. So the correct answer is optic chiasma, which can cause bitemporal hemianopia.
Yeah.
Now
Roma,
I'll go to...
Yeah, Roma, when I tell you to change the slide, only then change the slide, okay? Nobody will type now. Yeah, go ahead, Roma. Go. Yeah. Now project the question. Yeah.
So classic Sjogren syndrome consists of keratoconjunctivitis sicca, xerostomia, and A, eczema, B, arthritis, C, Raynaud's phenomena, D, SSA and SSB autoantibodies.
Team 3, please unmute yourself to answer.
Ma'am, option is D, SSA and SSB autoantibodies.
Okay, now let's see what's the answer. So you are wrong. The answer is B, arthritis. That's the classical triad. So we'll go to the next question.
Excuse me, ma'am. Ma'am, from gladiators, we had put 2 before 3.
No, for us, it is showing 3 before 2.
Okay.
You can all refer to the chat box.
Okay, ma'am.
Yeah.
Shall I move to the next question, please?
Yes, go ahead. I'm not to put the XX, so nobody will type, okay? Yeah, now go ahead.
Now we have audience questions. So the approximate age of onset for accommodative esotropia is A, 1-year-old, B, 3-year-old, C, 5-year-old, and D, 7-year-old.
So if any audience who is not the part of the team, if they know the answer, you can type I in the chat box. We'll ask you to unmute yourself.
Team 2, please unmute yourself to answer this one.
This is audience question, Ritu.
Okay, sorry.
Yeah.
There's nobody who has put.
So Dr. Sharan,
Dr. Sharan.
yeah, you can unmute yourself.
Ma'am, is it B?
Okay, now we'll see the correct answer. It's B, 3-year-old. So you are absolutely right, Dr. Sharan. Shall we go ahead with the next question?
Yes.
Glaucoma secondary to choroidal melanoma is usually A, chronic low-grade melanoma. Chronic low-grade, one second.
Yeah, so can we have team 2 gladiators unmute themselves?
Ma'am, it's 3 mechanical obstruction of the trabecular meshwork by tumor cells.
Can we have the answer, Dr. Roma?
One.
Ma'am, it was 5 before 2.
No, that was after XX. We have 2. Even
After
I
XXX only, please recheck, ma'am.
rechecked. I'll share the screenshot if you wish to.
So the correct answer is B, neovascular glaucoma.
What answer did they give, Ritu?
It is gladiators. Team 2 had first.
So they gave the correct answer, right?
Dr. Roma?
Yes. Shall I go ahead?
You can.
Okay, so the next question is, most ocular and orbital ultrasound is performed in the range of 1, 10 kilohertz, 2, 20 megahertz, 10 megahertz, or 20 kilohertz.
Team 3, dreaded drusenoids.
Wait. Don't answer. So they team dreaded drusenoids has just written that they gave the answer 3.
No, ma'am.
Team for Oculus Curatio had pressed their number before she read out the question. There was just a white screen.
So there's this confusion. Team dreaded drusenoid had written a comment rather than just trying to attempt.
Ma'am, it is both. Ma'am, it is both. It is comment also and 3 for the answer also.
Okay. You give the answer. Yeah.
Ma'am, answer is 3, 10 megahertz.
Okay. Dr. Roma, can we have the...
Yeah, so the answer is 10 megahertz. That's the right answer.
Okay.
So we'll move to the next question.
Wait, Roma, wait.
Okay, ma'am. Okay.
Okay, so there's one confusion. Yeah, so Team Gladiators had answered the previous question wrong. I've received that comments from 2 people. So Team Gladiator gets no mark, okay? And Team Dreaded Rusna gets +1. Okay? Yeah. Now, Roma, you move on.
Which one of the following concerning AD's tonic pupil is false? A, majority of affected patients will have unilateral involvement. B, patient may have accommodative symptoms of photophobia. C, pupillary constriction in response to pilocarpine 1% is conclusive evidence of denervation hypersensitivity. D, differential diagnosis of tonic pupil includes herpes zoster, syphilis, and giant cell arteritis.
So what I'm seeing, yeah. Ritu?
Please unmute yourself. Team 3, yes.
Yeah. Ma'am, the answer is C. Pupillary constriction in response to pilocarpine 1% is conclusive evidence of denervation hypersensitivity.
Can we have the answer, Dr. Roma?
Yes, ma'am. Just getting started. Just give me 1 second.
Yeah. Dr. Roma?
Yeah, it's not showing, but the correct answer is C. Pupillary that is the false statement because it's the response to the is pilocarpine 0.125, which is denervation hypersensitivity.
Okay, did they give the correct answer, Ritu?
Yes, ma'am, they did. Also, I would like to reiterate, I have been receiving the team numbers even after I type triple X or 4X. Please adhere to the rules.
Yeah, Roma, your slides are moving.
No, ma'am, it's getting stuck. I'm not able to share.
Can you
yet.
unshare the screen? Should I?
Yes,
Sameer,
ma'am.
can you do it? Do you want to share?
I'll do it, ma'am.
Yeah.
Team Luminescence has put up a comment. Team participants, please refer again. Whenever I type triple X or 4Xs, the first team which types their number will be unmuted. All right.
Just give me a second, ma'am.
And only after the question pops up, you'll have to write your team number.
We were on the 5th question, right?
Yes. 5th question was done.
Yeah, is it my slides are visible?
Yeah, so this question was done, Sameer. You can move on to the 6th question.
Shall I start?
Yes. No, wait, the question is not projected. Please.
No,
Participants.
This is not done.
No, that was the answer, ma'am.
So that's what they started typing before the question got projected.
Dr. Sameer will read out the question to you.
So, Ritu, let's do this. When Sameer projects the question, then let's type XXX, okay?
All right.
And whoever starts typing before that gets a -10.
Okay.
Yeah. Sameer, go on. Project your question.
We have a audience question next.
Okay.
The
Yeah.
question is, Duane syndrome is thought to result from a developmental abnormality of the A, trochlear nucleus, B, motor end plate, C, oculomotor nucleus, and D, abducens nucleus. So the audience can type in their, whosoever wants to answer can
Type I in the chat box. Any audience wants to answer this? Any of the participants you want to individually answer this, you can type I in the chat box. You can get the... So SNMC is typed I. So who wants to answer this? You can just unmute yourself and answer.
I mean, it's the abducens nucleus.
Okay. So can we have the answer?
The answer is correct. The answer is abducens.
Who answered this question?
Ma'am, Dr. Akshika.
Dr. Akshika.
SNMC I stars.
Yeah. Okay. Fine.
Just to confirm, there were two questions were answered correctly, and both were from team 3, right?
Yes. Yes, that's right.
Dreaded drucinoid.
Yes. So Sameer, you move on to the next question. Yeah, when it's, just wait for my XXX before you type. Yeah, move on, Sameer. Yeah.
Which of the following is the most important test to be performed in capillary hemangioma? A, echo, B, hearing test, C, EKG, and D, bleeding time.
So gladiators, team 2, you can unmute yourself.
Ma'am, it's the bleeding time.
Okay, Sameer, can we have the answer?
So the answer is correct. It's D, bleeding time.
Okay, so you get a +1 for that. Yeah. Okay, Sameer, move on to the next question.
I'll start reading the question.
First, project the question.
The most common ocular manifestation of congenital CMV infection is cataract, microphthalmia, C, retinochoroiditis, and D, strabismus.
Okay, team 3, dreaded drucinoids. You have to wait for the XXX before you press the buzzer. Yeah, dreaded drucinoids.
Ma'am, the answer is C, retinochoroiditis.
Okay, can we have the answer?
The answer is correct. It's retinochoroiditis.
Okay, fine.
Now we move on to the audience question. So, which procedure is the best treatment option for the repair of a large upper eyelid defect? A, Cutler beard, B, Bic, C, Hughes procedure, and D, Fasanella Servat.
So anybody from the audience other than the participants wants to answer this question, you can type an I in the chat box. No takers? Okay, the participants can type I if you know the answer. Okay, this is SNMC again. So Akshika, somebody besides you has to answer.
Yes, ma'am. It's C. Hughes.
So this is Akshika again, is it?
No, ma'am. It's Dr. Siddhi.
Okay, so can we have the answer?
Unfortunately, the answer is not correct. The correct answer is Cutler beard.
Okay.
So
Fine.
shall I read out the next question?
Next question. You wait for my XX before you press the buzzer. Sameer, you read out the next question. Yeah.
In photodynamic therapy, the role of the light source is to A. Activate the photosensitizer, initiating the photochemical reaction. B. Directly destroy abnormal blood vessels with heat. C. Reduce the inflammatory response in the retina. D. Increase the absorption of the photosensitizing agent.
Yeah. So team 2, you can unmute yourself.
Ma'am, it's A, activating the photosensitizer, initiating the photochemical reaction.
Can we have the answer?
So the answer is correct. PDT activates the photosensitizer and initiates the photochemical reaction.
Okay. Now, since the participants are getting too over enthusiastic about typing the buzzer even before the question is flashed, we'll have a negative marking for next 2 questions. Okay. So think before you type. If you give a wrong answer, you get a -5. Is that okay? And that's because you're too over enthusiastic, not waiting for us to, project the question. Okay. So -5 if you have a wrong answer. Yes. Go on, Samir.
So I'll read the next question.
Yeah.
A superior rectus fade-in suture is used for the treatment of which condition? A. Duane syndrome. B. Dissociated vertical deviation. C. Brown syndrome. And D. Double elevator palsy.
So team 2, you can unmute yourself.
Ma'am, I think it is C, Brown syndrome.
Can you give the answer?
The answer is incorrect. It's dissociated vertical deviation.
You get a -5 for this. Okay. Yeah. Can we have a next question? Yeah.
So the last question, which of the following is false concerning VKH disease? A. Skin findings precede ocular disease. B. Auditory symptoms may be present. C. Retinal detachments may cause vision loss. And D. There is thickened choroidal signal on B scan ultrasound.
So gladiators again.
देखो 1 है यार.
Skin findings precede ocular diseases.
So the answer is correct. It's skin findings precede ocular disease.
Okay. So you get a +1 for that. Yeah. Okay. So do we have 1 second? So luminescence, no, this was after typing XX. You have to wait for my XX on the chat box to appear. Okay. Yeah. So can we have do we have one more audience question? We are done with all the audience questions. I think there's one more audience question. Yeah.
We are done, ma'am.
We are done.
Okay, one audience question did not go to anybody. Yeah. Okay.
Just to summarize, is anyone else keeping score? I just want to correlate and we'll.
Yeah. So for me, gladiators has got a +3 and -5. So they at -2 in this round. Dreaded Drusenoids gets a +3.
Okay.
Is that correct?
Yes, ma'am.
Yes, ma'am.
So in future quizzes, we are going to have a negative marking because the teams are not following the rules. Okay. Yeah.
So we'll move on with the next round, which is round 4, wordsmith or unscramble. So I'll tell the rules. So rules for round 4 are: one pre-decided team member will play the round and there will be 6 jumbled words which will flash on your screen. The time to solve is 1 minute and there will be 1 mark for each correct answer. Okay. So one person has to unmute and they'll be speaking out the words, whatever they are saying on the screen. Okay. So let's have and it is team specific. So no one has to type anything into the chat box. So we'll have a trial round. So this is like this, 6 words will be displayed on your screen, which are jumbled, and the answer. So you'll have to be unscrambling all these words. For example, you'll have to read out whatever you can unscramble, and it can be in any order. Okay. So these are the name of the fruits. Okay. So again, the thing, and for you, all the words will be related to ophthalmology. Okay. So you will have 1 minute, and Ritu, can you please keep a timer ready?
I'm ready. Yes.
Okay. So team 1, luminescence, please be ready. I'll be displaying the words next. Okay. I'll give a countdown. 3, 2, 1.
Fovea.
Yeah.
Ancillary grade.
Okay. Just let me know when the time is over.
30 seconds left.
Papilledema?
No. You got 2 words correct. So the words were subluxation, fovea, enucleation, symblepharon, diplopia, and Amsler grid. So out of these 6 words, you got fovea and Amsler grid correct. So +2 for team 1 luminescence. So team 2 gladiators, please be ready. You let me know
Yes,
once
sir.
you're ready, please. Are you
Yes, sir,
ready?
I'm ready.
Okay, so I'll give a countdown from 3, 3, 2, 1. You can do it in any order.
Sir, fifth is hydrosis bulbi.
Okay, correct.
Fourth is lens.
Correct.
Sir, second is indocyanine green angiography.
Incorrect.
Sixth is keratoprosthesis.
Correct. Two more to go. So you got 4 words correct. The first one was dorsalamide, second was indocyanine green angiography, third was atropine, then lens, siderosis bulbi, and keratoprosthesis. So +4 for team 2 gladiators. Team 3, are you ready?
नहीं बताना. Yes, sir.
You ready?
Yes, sir.
Okay. So I'll give a countdown from 3 and then I'll show the slide. Okay. 3, 2, 1.
Ma'am, first is head. Sir, first is head start. Orbit.
Okay.
Fifth is orbit.
Okay.
Sixth is evisceration. Third is Ishtiara chart.
Okay.
Fourth is Sherman's test.
Only one person should answer.
Ma'am, sir, 2 is ptosis and fourth is Sherman test.
Okay. Great. Excellent.
Are you-
All six are correct. Hess chart, ptosis, Ishihara chart, Shermer's test, orbit, and evisceration. Okay, good. Now next team 4 oculus curatio. Are you ready?
Yes, sir.
Okay, I'll count down from 3 and then I'll show the slide.
Yes.
Okay. 3, 2, 1.
Okay. Fourth is nystagmus.
Okay.
Sir.
15 more seconds.
Yes, sir. Second exotropia.
Okay. You got 2 words correct. So first is entropion,
Yes,
second
sir.
isotropia, then proptosis, nystagmus, and then chorea. So we'll move on to the last team. Team 5, SNMC I-stars. Are you ready?
Yes, sir.
Okay, so I'll count down from 3 and then I'll show the slide, okay? 3, 2, 1.
So third one is conjunctiva.
Okay.
Mhm.
Come on, 30 more seconds to go.
Second is cupping.
Okay. Got two answers, two words correct. So first is canaliculus, then it's cupping, conjunctiva, dacryocystitis, ectropion, and then dryness. So just to summarize the score of this round, team 1 got 2 correct, so +2. Team 2 got 4 correct, so +4. Team 3 got all correct, so +6. Team 4 and team 5 both got 2 correct, so +2 for each team. So now I would like to, with this, we come to the end of our prelim session, and I would like to invite Dr. Nupur ma'am to give the vote of thanks and facilitate our participants.
So thank you to all the participants today. We've had a wonderful YOSI iROCK session. I think there was some confusion with the quiz thing, So we'll just, sort that out offline. But the rules are very clear. After typing the XXX, whosoever team's number we get, we will ask them to unmute and then speak out. And it is what we are seeing. We are cross-checking with each other. So I hope there's no, heartburn on that aspect. Leaving that aside, I think we've had a wonderful session and I'm so proud, the entire YOSI is so proud of all of you for putting in so much efforts and your enthusiasm. Really, once again, I would like to comment, that you are at JR level and still you're putting in so much efforts. We're so happy to see that and hope that, you all will continue to participate in the YOSI activities in the future as well. And the session was as much enjoyable it was to you as it was to us. I would also like to thank the moderator team for today, Dr. Sami, Dr. Roma, Dr. Ritu for, so seamlessly conducting this session and doing such a fantabulous job. So thank you to all three of you, to the entire YOSI iROCK team. As I mentioned before, that the team has been working very hard to put up all these sessions, to the entire YOSI Governing Council, Dr. Devakan, Dr. Nilesh, for their unending support, to the iROCK sessions. To our esteemed judges, we had some wonderful comments. And that's it from our side. If I've missed anybody or anything, Samir, you can just add on to it. Yeah.
If I may, I would just like to say something.
Yeah, tell me.
First of all, I would like to, thank and, Nupur ma'am. It was her idea to bring up, to come up with this, and she has been working day and night from its starting, and she has been there for all prelim sessions, helping us out, guiding us with each and every small thing. So big hats off to Dr. Nupur ma'am for, uh, organizing all this entire big event. And one more thing, it doesn't matter whosoever wins at the end. Okay, it's a great, it's a big thing that in your second year, third year, first year, whatever, during your residency, you're participating in things. So exposure is much more important. Your presentation skills, what you take out, take from this presentation is very important. So I just want to give one tip, that whenever you're presenting something, whether it's a presentation or whether it's a video, use English. Okay. So Hindi is, there might be some judges or, there might be someone in jury who might not understand Hindi. whether it can be from any place. So just try to use a universal language, because the judges, although the judge might or may not know the language, and sometimes the judges might even get pissed. Just one small thing which I wanted to tell you people: whenever you're presenting, just use a universal language. So now, and Ritu or Roma ma'am, would you like to say anything?
I was just about to say about the very same reel. It was interesting, but was done in Hindi. So yeah. Also, lovely presentations, lovely reels. I was thinking someone from the teams would come up with a dance, but nobody seems to present dance or music, only reels. Anyway, we had a wonderful session. Thank you, Nupur ma'am.
Thank you, ma'am, for
You
such a
are-
wonderful learning session. And all participants were really good.
There's a question in the chat box by Dr. Sharan. If the videos can use regional languages. Yes, if informative and you're conversing between a patient to showcase that's how you work in the OPD, you can. But if you're delivering.
So for that, you always put some subtitles. So if you're using some other language, always put English subtitles. But one video, I think, I don't remember which team, who were conversing in Hindi, and they, like, the Hindi language was used, and even the subtitles were although written in English, but the language was Hindi. So if you're talking in any other language, please use English subtitles so that the whosoever is watching it can understand. Okay. So ma'am, Nupur ma'am, would you like to present them, facilitate them?
Yeah. So we would like to just present the certificates of participation who've been so, nicely designed by Dr. Sami. So Dr. Riddhima, congratulations for your participation. Dr. Ria, Dr. Rajendra Prasad, Dr. Shreya, Dr. Monica, Dr. Chirag, Dr. Mehak, Dr. Shireen, Dr. Ayush, Dr. Saurabh, Dr. Abhinav, Dr. Uttara, and Dr. Akshika, Dr. Siddhi, Dr. Vinish. Yeah, so that's it. You have any feedback or anything, you can get in touch with us. So your prizes, of the previous sessions and this sessions will also be, shortly sent to you. We'll intimate you regarding that. The certificates will be sent to you on the WhatsApp group by Dr. Samir shortly after. We are compiling the results. So as Dr. Samir has already mentioned that, whoever wins or loses is not important. Participation is more important. Each of you here is a winner. And, thank you so much from the bottom of our hearts for taking time out and your efforts for participating in this event. We look forward to having you, all of you. YOSI is a beautiful community. There's lots to offer to all the budding ophthalmologists like yourself. Please make use of this platform. You're the future YOSI leaders and the ophthalmology leaders. This is just the beginning. And I would also like to thank the Numerotech team, Sai and Manjula ji for their support, back-end support. They're always there with us. Thank you so much for that. And with this, we can just wrap up the session and we can stop the live streaming, and I'll request everybody to stay back for a quick group photograph. Yeah. So
All of
Manjula
us
ji.
are, all of you are invited to YOSICon.
Yes.
So we are having our annual conference in September from 5th to 7th. So we hope abstract submissions are open. So we request you to whatever participate in the conference and do come.
Yes. And we have some very nice initiatives started by Dr. Devakant and Dr. Nilesh, something called as a Say Yes to Podium. So you can actually have a mentored podium presentation. We can share those flyers with you. Also, there is something called as a Future Leader Academy of, Dr. Devakant has started a very nice initiative. We'll share the flyers with you. Please do make use of, these are for you, so make use of those opportunities. And so can we stop the live streaming, Manjula? Is it stopped? Yeah.
1 second, doctor.
Yes.